Okay, we'll make a start. So good morning, everyone, and thank you for attending today for this Innovation Insights webinar. Today, we're going to be talking about using a validated whole system 7-phase approach to successfully implement large-scale change across an ICS. Speakers today will include myself, Ruth Dales, Gill Gookey, and Rich McBain. Each one of us will introduce at the start of our slides that we're presenting. Your microphones will be muted, and there will be time for questions at the end once all the speakers have finished. So I'm just going to cover briefly who we are as a health innovation network, and then we'll move into the topic for today. We are the health innovation adoption experts. We support health and social care teams to find, test, and implement new solutions at scale. You can see some of our statistics at the bottom of this page over the last 5 to 7 years. There are 15 health innovation networks in the UK, and we are talking today from the East Midlands. We tackle national problems in locally tailored ways and in partnerships with our local systems so that everyone benefits from innovation. So I'm going to hand over to our first speaker now. So that's handing over to you, Ruth. You're on mute, Ruth.
It's always a great start, isn't it? Well, first of all, can I thank Health Innovation East Midlands and the Health Innovation Network for allowing me the opportunity to come to you today and describe some of the work that we do with the Health Innovation Networks through the National Medicine Safety Improvement Programme. So today we're going to be looking at the whole systems approach framework, the 7-phase whole systems approach framework. During that, I'm going to flash up some slides that will talk about the impact that programme's had. But I think it's really crucial to emphasise that impact is a collective impact from across the country. So this isn't NHS England, this is everybody. This is a real collective endeavour from frontline teams, lived experience, community services, all the way through to ICBs, the patient safety collaboratives that support them, regional and national colleagues, all driving towards this improvement. And it really is a real privilege. I think I find it quite personally satisfying to be able to work on programmes like this. So I'm really excited today to describe to you one of the improvement approaches that we use, which is the 7-phase whole systems approach framework. So if we move in, oh, I've done the wrong thing to go to the next slide. Here we go. Okay, so the Med Safety Improvement Programme brings the science of continuous safety improvement to bear on complex problems. So these are the sorts of problems that people have known about for years and that continue to challenge our health and care system. So at that point, we usually bring them up to the national level and we think, how can we think about this differently? And rather than describe the specific solutions that need to be put in place, these complex problems usually require a local approach. And so we create the conditions that enable and support that local innovation. So where did our journey begin with the whole systems approach framework? Well, it began with pain. So in 2019, Public Health England published the Dependence Forming Medicines Review, and a key recommendation from there was that all parts of the health and care system and the general population were going to need to engage with this complex problem if we were going to be able to find solutions. And they pointed out that the strategic leadership of ICSs was going to be vital. So the Medicine Safety Improvement Programme, so that's myself and a gentleman called Tony Jameson, we recognised that this complex problem required a national coordination to help improvement happen both locally but at that national scale. So we undertook a discovery stage through 2021, and it became clear that a whole systems approach was going to be key. So our frontline people were telling us a whole systems approach was key, as well as our Public Health England colleagues as well. So then I had the task of developing an implementation strategy, and although we knew a whole systems approach was warranted, we actually found ourselves in a vacuum of how to operationalise one. So at the time, there was a systematic review that described the evidence of how to operationalise a whole systems approach, and they felt that it was in its infancy. So there was a small amount of evidence of how to operationalise the sort of processes of getting people together to think about things as a system, but crucially, there was little evidence of doing that and an outcome at the end, which we could find published anywhere. So people may have been doing it, but it wasn't published. So I found myself faced with the need to develop a whole systems approach framework that would serve this programme, plus an implementation plan to operationalise it. So if we fast forward, so 4.5 years later, we've got some impact, which is sustaining. So there's lots of different ways that we can display data on the screen now. This is a statistical process control chart. And it represents the rate of prescribing of chronic use of opioids in adults in England over time. And this is of all registered adults in GP surgeries. So as you can see, we had a discovery period which served as our baseline, and you can see a steady improvement there that then is maintained. There's obviously lots of different ways to display data. In improvement, we like to use statistical process control because it allows us to differentiate between common cause and variation that might have happened, regardless, or whether or not there's some special cause which we can potentially attribute to our programme. So we're really proud of this particular chart. This is a national level chart, and it shows that we've got over 56,000 fewer adults being prescribed opioids for chronic pain since the start of the programme. And doing some fancy maths, we can turn that into over 900 lives saved. And there's other ways you can look at it. Often people look at data on a much longer time frame like this. So you might do some projections. So the orange bit here represents all of the time scale back to what we've got, which goes all the way back to 2015 of this data. And that, as you can see, there's an upward trend there. And then once we got involved from sort of 2020, 21, you can see that it starts to level off and we've got some improvement. Depending on what projections you use, you could claim different lives saved, but we prefer the SPC route because it actually represents the figures as they happened, not as a sort of a forecast, if you like. Okay, so that's some improvement, national improvement. But how did we get there? So nationally, from our national perspective, we create a strong theory of change. And this is so important for complex programs because it's not a linear cause and effect. It's not you do this one thing, you'll get this result at the end. It's often very complex. So the national theory of change is based on that 12 months worth of discovery and development that we did. Now, there's a lot on this slide. I'm not expecting you to absorb it, though you're more than welcome to have a copy of it. What we're going to do is focus today on this bit here, which is talking about that 7-phase whole systems approach framework. And crucially, what this slide is trying to show is that we didn't just produce a whole systems approach framework and put it on a website and direct people to it. That's one way of supporting the system. We felt that we needed that coordinated approach. And so we have some wraparound strategies that we put in place nationally. And a key one of those was commissioning the patient safety collaboratives through the HINs to support ICBs through this approach. And we feel that it's a real key part of it. For us, it's not just to point out how you might solve it, it's to actually help our systems across the country to do that. So like I've just said, our theory of change is to mobilise the activity at macro, meso and micro levels of the healthcare systems. Basically, that means helping the frontline staff, patients, public, to enact change. And also we have support through the ICB level and also through regions and nationally as well. So this is on the screen now is our whole systems approach framework. It's this one specifically relating to chronic pain. So the words on there relate to chronic pain and opioids. As you can see, it's got 7 phases. You start some phases 1, 2 and 3 are all about developing that shared understanding of the local problem. So this is what an ICB would be attempting to do with all of its places, etc. So how do we create a shared understanding of that local problem? Then once we know that, we can move into a period of what we hope is improvement. You could call it change because we know not all change is an improvement, but the idea is we want to get to improvement. So we get an action plan and we get a wide stakeholder network and we go into improvement activity. And then, of course, we have to think about sustainability. How do we sustain that? As you work through the stages in order, the network forms, and that becomes key to the momentum that drives this the work forwards. So this is where it started. It actually evolved the whole systems approach framework, as you'd hope, because this is complex framework. As I said at the beginning, there was we were working from a kind of a theory of change. So the method developed as we went along. This is much more similar to the Public Health England approach to obesity, which is where I drew my inspiration for the first sort of 4 to 5 phases from. But we learned over time that by watching how it was being implemented by our HINs in the different ICBs, we learned that tweaks needed to be made. So the first one we made was to do with how we describe the programme, because we learned that words matter. So we changed from, I'll just click back, so we changed from high risk opioid prescribing through to reducing harm from chronic non-cancer pain, because what we found was the words meant that we were people naturally self-selected whether they wanted to be involved in the programme or not based on the words they read. So this was very pharmacy focused, whereas what we needed was that more holistic view of chronic pain. So that was important. And then eventually it evolved to this, where you can see that phase 5 has come out and it's gone into the middle. And this was observed really because we felt that phase 5 was not really a standalone phase as it was depicted in the first iteration. And it was more that all of the previous phases and subsequent ones kind of built towards that network growing and maturing as it went along, and they contribute to its maintenance. And crucially, the engine becomes the network becomes that engine that drives the improvement and sustains that that sort of level of quality. And what we observed with our PSCs and ICBs that invested the time in developing and nurturing that network, that was a diverse and activated network, is they appear to be a lot better able to withstand shocks that came along their way, which happen all the time in healthcare, don't they? Which things like staff changes or even the removal of the National Incentive Scheme. And this meant that they were able, if they had a really activated network, they were able to go back to, say, phase 1 if they'd lost a key leadership post, and recruit from their network, and then start again, and then pop back up to action. They would revisit, for example, their action phase, having, say, done 12 months of work on it. They might revisit and just tick off, what have we done, what have we achieved, what do we need to add on? So moving phase 5 to the middle was super important. Now, this slide is just some feedback, really. So we have the graphs which describe that quantitative output, with the impact that we wanted to achieve. There were our main outcomes. But as we went along, we asked people who were undertaking the programme, how does it feel to do this? So these are some quotes about how it felt to go through phases 1, 2, 3, 4, and 5, and you can see that people really started to understand the importance of bringing the system together to find siloed pieces of work, bring them under the one umbrella, and also to get that wide range of stakeholders activated and motivated to take the work forward and come up with solutions. And then at the end of the programme, we went back to one of our ICBs that had some really impressive improvements, and we wanted to understand whether this would have happened with or without us. And the reason we went to this particular ICB was they had been working on opioids and chronic pain for a number of years prior to the launch of the MedSit programme, and we wanted to understand how much did they value really the addition of our programme onto the work that they were already doing. And I invited them to present their work to me, and impromptu, these are the quotes that I got from some of the leadership from the ICB, which is that although they had that work, they really felt that having the PSC support to undertake that whole systems approach really allowed them to gain momentum, gain different perspectives and better understanding of how they could take this work forward. So they really did feel that the approach was helpful to them. So just to quickly say, the whole systems approach framework that I displayed obviously had the 7 phases with a brief description underneath. That's kind of just the surface. On Futures, we have a little page for each of the phases, and you can access more sort of key steps on how to undertake them on there, and ideas of how you might, for example, undertake a workshop to do this. So we'll pop the link in Futures in the chat, so you're all welcome to come and join and have a flick through those Futures pages at your own pace. So that's the story of how we got to a whole systems approach. And now I'm going to pass over to Gill, who's going to describe some local insight.
Thanks, Ruth. So yeah, I'm Gill Gookey. I'm Head of Motor and Safety Programme Delivery at Health Innovation East Midlands. I'm going to spend the next few minutes describing how we got off the starting blocks with the whole system approach, and maybe through to phase 1, really translating that theory and model Ruth has described and how we put it into practice. I'm always very cognizant when we receive a commission like MedSit that we are receiving NHS funds, and therefore I need to be really mindful that we allocate the resource and capacity that the Commission affords to NHS systems in a way that will maximise the opportunity for improvements and positive impact, but it also needs to be delivered in a way that recognises the local context, including whether it's the right time for that system. To set the scene for the Midlands, for the East Midlands, we currently have 5 ICSs in our geography, and we don't necessarily work with all ICSs on all commissions, or have all ICSs join us at the same timeline. It can vary. So where to start? The first thing I need to do is take some time to understand the programme, its aims, the clinical context, and any measures that are being suggested, perhaps comparing the data from the different systems to see if there's any variation. I then find my gurus, those people that are absolutely embedded in the system, know the speciality really well, the people and the systems, and really listen to what they have to say and check my early thinking. Listen to how they describe the local context and the challenges, bearing in mind that no two systems are the same. They've usually been working for years trying to improve care in that speciality, so I can learn from them what's worked and what hasn't, and really understand what they would advocate as being safe improvements in care, the models that they would be supporting and those that we shouldn't be encouraging. So for opioids, it was really clear that we should be supporting a patient-led deprescribing approach with non-pharmacological support, and we would definitely not be supporting any routine enforced tapering. Accessing your guru's address book at this stage is also a key outcome, and hopefully obtaining their mentoring support during the programme. For me, even if you have experience in a speciality, having other people that can mentor you during the programme and sense check you, keep you on the right track, it's really important. Only after doing that will we as a HEAM, Health Innovation East Midlands, agree our programme approach. And that includes what we're going to offer to the system, but also considering what we might want from the system to commit from the system to be able to deliver the programme properly. And that's taken into account that whole system approach. And that allows us to have some really open and transparent conversations with our systems to work out who's the right collaboration and whether it's the right time for them. So once we've done that and we've agreed who we're working with, we develop our core working group. And I thought it might be interesting to share what we think is our golden threads for setting up this work when we get into phase one. First thing for me is making sure this programme's a priority in the system, and that's exec level support and sponsorship. It's around positioning that programme strategically and ensuring that you've got the right governance, because this will allow you to navigate the speed bumps and shocks, as Ruth described it, that come along the way during the programme lifetime. If you're really struggling to get that set up early in the programme, it's a little red flag for me as to whether it's the right time for the system. Next thing is talking about the ways of working. We're taking a system approach, so it should be system owned. For us as HEAM, we're there for support, advice, resources. We will be your biggest cheerleaders in that team, but the system should remain the decision maker and the owner. Our SROs, when we do a whole system approach, are taken from the system. Those senior responsible officers, they're people within the system with decision making capability. The next one in green, we're taking a system approach, so we want to involve everybody. Think really wide. For the pain programme, we thought about physiotherapists, social prescribers, community groups, substance misuse. We didn't necessarily know all of those at the start. We started small and we grew. And what Ruth was describing earlier with the network, we thought about ways that everybody could be involved in the scope and ability that they can with their competing needs. That might mean that people have to be intermittent in their support or just join you for a little bit of a task and finish. But when you're doing that and managing your network, think about your communication and to that wider network, how you're going to do that well and often to keep everybody engaged. Lived experience involvement throughout are non-negotiable for me, but I would do it. How you do that depends on the programme you're delivering with the whole system approach. I'd advocate that you listen early. Their voice is really loud about what improvements that they'd like to hear, and you'll usually gather people that want to come on your improvement journey. For us, we did a people in communities event early with the pain programme and also worked with Health Watch, who were brilliant. That allowed us to collate a load of people that were able to share their stories of lived experience, but also come with us on the journey. We embedded it into, there was lived experience with a seat at every table, equal decision-making rights. And that was a really positive approach. But how you might do that on your different whole system approach, you might need to discuss. The next thing is how you're going to improve. For us, it's around supported improvement. So we wanted a real emphasis on shared learning, using quality improvement techniques, using data, but to drive improvements, definitely avoiding targets, blame, finger pointing in any way. They're my 5 key ones that we started with early in delivering a whole system approach, and we've kept them into the next programme too. However, I have added a 6th, and that would definitely be there from now on, and that's around sustainability, which Kate's going to describe in a second. The next thing I'd want to suggest is, for a whole system approach, it's a marathon and not a sprint. So I'm going to suggest a bit of a mindset to maybe consider when you're starting this approach. If we go back to what Ruth described early on in the first one, we're about enabling and supporting local innovation rather than dictating it. For us, in our experience, the system wants to improve. We just need to support it to do so. Can I just pause for a second? Can anybody hear me?
Yeah, we can.
Yeah, we can all hear you.
We can. Everybody froze for me for a second, and I just wondered whether my computer had gone down. So yeah, the system wants to improve. We just need to support it to do so, and that might mean giving it some infrastructure and the opportunity to. But it tends to know how it wants to improve. The next thing I would suggest is name your constraints, and then you can accept them. This manages expectations. If you're not coming with extra money, or if you're not going to, your programs are not providing a big pocket full of clinicians, then admit that early on, and then people can accept it and they don't expect it. Cooperative reciprocal relationships are absolutely crucial. They are built on trust. Trust is going to be built on these small interactions and actions over a period of time. So accept that you're going to have to spend a little time building those, and they're absolutely core to the programme. The next one's be flexible. We're in the NHS. Change is definitely inevitable. I think my favourite word on these programmes is pivot, and success will be incremental. It's unlikely to be big bang, but that's okay. And my last one would be, I think, my most important, in which is to celebrate the wins, however small. We've all put a lot of tenacity, time and effort into achieving them, and they're absolutely crucial. So celebrate them whenever you can. So they're my top tips for getting through phase 1. I'm now going to hand over to Kate to take us through the next stages.
Hi everyone. Yeah, thank you, Jill. So I'm Kate, and I'm just going to talk through the MedSip Commission in the East Midlands between 2022 and 2025. So I'm Senior Improvement Lead here at Health Innovation East Midlands, so was leading on the local delivery of that within our systems. So we predominantly worked with Derby and Derbyshire, and also Lincolnshire in sort of the closing stages in the last year or so of the programme. So Jill has explained how phase 1 was achieved. So obviously I'm not going to talk about that again, but I'm just going to more talk about sort of what and why we did this, what we did in the East Midlands through the other stages. So phase 2 and 3. So what we found really beneficial was building that ICS picture and mapping the system all at the same time. So the reason being, mapping was naturally happening when we were having conversations. So doing them both at the same time just seemed to streamline the process much better. We did this by having one-to-one conversations, interviews, and really building those relationships, like Jill mentioned, to get that honesty and build trust with our stakeholders, and making sure we were really inclusive of local communities and those with lived experience, so that golden thread of lived experience voices that Jill mentioned already maintained that patient-centred focus throughout the whole of our programme and the whole of all of the stages. This allowed us to create an accurate and clear picture of prescribing across the region, so both Derbyshire and Lincolnshire, to develop that shared understanding of how chronic non-cancer pain could be addressed at our ICS levels. This was key with stakeholders so that they could be involved, and they were involved at validating that picture of the system that we were creating. It's their system, like Jill said, we're just there to support. We still collected the national, local and practice level data that was reflective of the health inequalities and service provision. Looking at the system as a whole and speaking to that wide scope of people allowed us to really establish what other commissioned non-pharmacological support was available. And that was also necessary to really keep sort of physiotherapy, substance misuse, social prescribers and health and wellbeing coaches involved in those conversations, because they were providing that. Equally, it really helped us to create advocates across the system and champions. We were doing this as a whole system approach. We needed pockets of people everywhere to be championing this throughout. So that was really key to help us build and maintain momentum and engagement moving forward. So moving into that phase 4 and the action planning, once that initial mapping was complete, we brought everyone together in one online action planning event. There were key stakeholders there, lived experience, and also key decision makers in attendance, as Gill said. So having those key decision makers there at this point meant that all the issues raised, solutions, actions that were raised could be prioritised, and there was high engagement, and these attendees could then commit to the working groups to action the clear mandate that was agreed by all. So moving into that phase 5, in Derbyshire, it was those working groups were split into 3 to set the momentum in the 3 work goal areas. Lincolnshire came into the programme slightly later and had 1, as I mentioned, but the working groups were vital to developing resources, guidelines, embedding policy, provision of funding for training, local website development, building really strong relationships to manage that network across the county, and also creating a really lovely community of practice so that, again, we could continue that shared learning and get that shared learning moving forward even when we stepped away from the programme. Phase 6, so whilst everyone was taking action in their working groups, we continuously monitored each region's local data and national data to monitor trends via EPACT in the national dashboard. However, quantitative data doesn't give the whole picture. So in order to maintain the spotlight on the importance of including lived experience, as we already mentioned, we also completed a qualitative review, really going back to those lived experience people and having a look at how those pain support groups, which I'll come into in a bit more detail in a minute, really helped, and how they were benefiting people, really helped to build the narrative to support the quantitative changes that we were seeing, that Ruth's obviously shed a little bit of light to as well. But about sustainability, so that phase 7, as Gill mentioned, it's something that we need to consider a bit earlier on in the programme now. One of our biggest learning points from the delivery was all around sustainability planning. For this programme, we started this in April 2024, so 12 months prior to the programme closing. However, these conversations were really quite challenging, with lots of competing priorities happening in the ICS. It was delayed due to getting sort of commitment for continuity and decision of who was going to look after it, who was going to be the long-term home for the programme. But after convening with lots of stakeholders over the 12-month period, by March 2025, we had a shared ownership agreement between, so in Derbyshire, we had 3 separate organisations taking the lead, so under MSK, Place and Partnerships and Medicine Optimisation. In hindsight, those conversations potentially should have started at the outset of the programme, which is one of our big learning points. But even though we're pretty confident that even if we had started really early, it probably would have changed. But it's more about keeping sustainability as that key priority from early on and keeping it as a key focus, regardless of which phase of the programme, so that it always stays at the forefront of people's mind. And it's one of the biggest recommendations we'd probably give to anybody planning on using this model, which I know Gill alluded to as well. So I wanted to just bring up some highlights from our region from this project. So we supported in the training of 120 Live Well with Pain practitioners to deliver pain support groups across Derbyshire and Lincolnshire. So we increased the pain support groups, as I just mentioned, were increased from 1 to 22 by having that uplift in trained practitioners. We halved the risk of opioid-related death for 677 people by stopping the prescription of high-dose opioids, and avoided 599 readmissions to hospital. Developed a large legacy suite of resources that are freely available. I think in this approach, one of the key things that we're most proud of is that non-pharmacological support that was increased. So those first 2 boxes that I mentioned, the increase in the pain practitioners and the support groups. Working as a system allowed us to allowed this increase to happen, which led to a reduction in overall prescribing. If we just focused on the prescribing and not that surrounding things to support these people as they come off their opioids, I don't think we would have necessarily achieved the outcomes that we did on their own. So I mentioned the qualitative review that we did alongside obviously collecting the quantitative data, and I'll show you the graphs in a minute, but I just wanted to put up these 4 key quotes that we pulled out from our review that we did, because having the living experience opinions and feelings really gave us incredible insight into how the increase in the non-pharmacological support had really helped them. So you can see from the top one, coming off strong medication had a positive impact, comments like they loved it and I wish there was more. But the most profound one is the second one. The value of peer support for these people suffering with chronic non-cancer pain and being on strong medication can be very profound. So I'm just going to read this one. I'm not sure I'd still be alive if it wasn't for this group. I didn't previously go out and I struggled with my mental health, but this group made me realise I'm worthy. It saved me. The group of people showed me I'm not alone and have no judgment towards me. So I think this is a really powerful quote about the benefit of this non-pharmacological support for these people. So here's a quick overview from both regions. Where the blue dots start was where the programme started locally. So Lincolnshire on the left, Derbyshire on the right. You can see a clear reduction in the high dose opioids. The chronic use did also go down, which I'll show you on the next couple of slides. But I think it's just worth mentioning that these aren't medications that can just be stopped. So tapering is needed. So there was always going to be a slower reduction in the chronic use as people were moving from the higher dose to the lower dose, and then hopefully in time completely off. So here you can see the chronic use for Derby and Derbyshire and see that those numbers have gone down. And as Ruth mentioned earlier, you can do some fancy maths to work out how many lives are saved. But you can see here that between 2021 and 2025, there were 24 lives saved in Derby and Derbyshire. Obviously, I mentioned that our commission started in 2022, but all of the discussions in the national pipeline started in 2021. So those discussions do start changes much earlier because you're raising awareness already. So the programme was already starting to have an impact, which is brilliant. So 24 lives saved in Derbyshire and then 22 lives saved in Lincolnshire over that period of time. So really, really lovely graphs to demonstrate that. And a few people have said they love an SPC. So here you go, showing you them again. So over the 3 years of the programme, there was a lot of lessons learned. So this is a bit of a busy slide, I'm sorry, and I'm not going to go into loads of detail because I am going to hand over to my colleague Rich soon, who's leading the 25-26 commission in the new programme. So you will see this slide again, and Rich is going to discuss how we've taken these key learnings forward into the new programme. So I didn't want to just go into them in loads of details now. So I think I will now hand over to Rich to go into that in a little bit more detail.
Thank you, Kate. Hello, yes, I'm Rich McBain. I'm one of the senior improvement leads here at Health Innovation East Midlands, and I am lucky enough to be working on the MedSIP Commission for the 25-26, which has a very long-winded title of helping people with a learning disability who have behaviour challenges to avoid harm from psychotropic medicines. The new Medicine Safety Commission, as I said, looks at helping people with a learning disability. The initial ask from NHS England was to work with one system using the full system approach to develop a map of the service and then lead on to action planning sessions as in stage 4. At HEAM, we decided to implement the previous learning from Gill and what Kate have talked about. And for various reasons, we've ended up working with 2 systems, Northamptonshire and Leicestershire. The programme, as we know, is particularly complex. It affects all healthcare settings, many various pathways and lots of services. It involves complex medications and complex populations. We know from previous work that there's over 1.3 million people with a learning disability in England. We know that from LEADER that many of them are going to die up to more than 20 years earlier. 42% of deaths are avoidable. We also know, as of 2015, that there were between 30 to 35,000 adults prescribed psychotropics that did not have the conditions for the medication that is indicated for. Compared to the general population, people with learning disabilities are more likely to be prescribed antipsychotics and more likely to be prescribed antidepressants. We also know, and I think this is one of the big things, that Stomp, Stamp and the LEADER have been around for many, many years. Numbers have not significantly changed. There's a lot of work out there, but it's not particularly making the impact that we wanted it to. So what we've tried to do here in the East Midlands is use the previous learnings, and we knew that initially we wanted to focus on 3 elements: that high level or executive level buy-in, finding the long-term home, and as Jill said, implementing sustainability from the start. We all know that without the high level buy-in or knowing where ownership's going to be, it's unlikely that any work will be maintained or any progress will be significant. Ultimately, if the executive team and any organisation don't engage, it becomes a struggle, particularly longer term. Thankfully, we were able to get this buy-in and get this long-term home, but we were also able to get a clinical advisor from NHS England to help with the initial work, direct it. So we've been able to find key advocates regionally and locally. The board level buy-in meant that we were able to find a long-term home across both systems, which is the Learning Disability and Autism Collaboratives. And as well as being the place for the work, once we'd finished, the LDA were also going to provide the governance for the programme. So we managed to achieve 3 things really, really early on, which was really significant, I think, in the progress that we've made. It also, having this long-term home, helped us proceed with the whole system approach, because they were able to advise where and who we should start with for informal meetings. That the appreciative inquiry element helped. The meetings, I've got to say, have been incredibly interesting, heartwarming. There's so much passion and enthusiasm from this clinical group that it really helped us understand the work that's happening, what the pitfalls are, but also helped us map the systems for both NHS and non-NHS badge organisations. We've met with some brilliant charities, met with some fascinating people that work in local authorities, and they're all keen to really make that improvements. We were at all times throughout this phase especially keen to make the role of the PSC clear. As Gill said, it's the ICS's system. We're not there to govern it, we're not there to run it, or we are there to help them map it, help them understand it, and establish where improvement focus and the action planning from stage 4 should be. We're not responsible for the system, we're not responsible for clinicians undertaking the work. Also, and this is something that I think has come through at all parts, we're not there to blame anyone. Medications that aren't necessarily licensed but are pivotal in helping in a crisis are key. They can really help things. We're not there to blame people for doing that. This sort of level of work and interaction that we took in, it allowed us to set the boundaries, all know what constraints we were working in, and go from there. The learning from the previous mission also showed us that thinking about data helps direct focus. We were lucky that the national team helped develop some searches that allowed specific data collection to be easily managed. And this was something that we got set up with the ICSs really early. As the programme's focused on people with a learning disability population, health inequality data was really useful to help us understand the current landscape and highlight target areas, particularly when thinking about stage 4 of the 7 steps and when we get to the action planning phase in January. Another key learning from the previous commission, but one that's been more apparent to me, is that relationship building takes time. When using, and this is something that Ruth said, when using the whole system 7-step approach, you do wide scale engagement. This is something that cannot be done well quickly. You could do it well, or you can do it quickly. It can't be done at the same time. The more time, energy and effort you put into the relationships, the better outcome and outputs you get. And this has helped us bring out the maps. Now, it's quite a busy map, but as you can see, it's fully comprehensive. We've developed 4 maps, 2 for each system, 1 in adults and 1 for child and young persons. But it is also important to point out that services change. This is a map of the current service for adults in the current situation, but it's going to be iterative. It's going to change over time. As you can see, the maps clearly highlight the complexity and scope of the pathway for people with learning disabilities, for their families, their carers, and even the staff to navigate. However, we have been able to work out when the prescribing may take place, where the benefit for patients occurs, and where initial points of action planning should or could be focused. Again, it's not for us to really say, it's for the system themselves to come up with. The map shows the complexity in system and services due to the often changing needs, where interventions also need to link together. But it also shows just how much the learning disability services cross boundaries between NHS badged, non-NHS badged services, charities, and various other providers. Having the map also helps us to work through the system from a personas point of view. And we've been again lucky that the national team have developed 4 hypothetical patients that help us stress test the system, stress test the maps to show where pitfalls may be or where services and stages might be bypassed to get earlier success. I'm now going to hand back over to Ruth just to summarise.
Thanks, Rich. Thanks, Kate and Gill. I think hearing from Health Innovation East Midlands on their learnings is so helpful, and it brings me joy as well, because I'm not working in their organisation, so I'm always at that little bit of an arm's length. So I love to hear how the learnings from what's going on more on the ground. So we've heard from them about the key learnings from implementing that 7-phase approach for chronic pain, and then how they've then incorporated that learning into their current programme, which is currently in flight as well. And I think in summary, what we're saying is that we've got a 7-phase whole systems approach that enables diverse stakeholders to understand their local problem, coordinate change ideas, and consider how to sustain improvement across what is a complex pathway of care. And crucially, by working through these 7 phases, you're encouraged locally to involve everyone, including lived experience and non-NHS. That's crucial when we talk about a whole system. We're not just talking about a whole NHS system, we are talking about people, communities, voluntary services, etc., and social care. Crucially, it enables you to leverage those social networks, which are so key to the improvement happening on the ground, and also the sustainability. And importantly, with that improvement lens, it's developing that improvement and learning cycle as a system on the way to hopefully the ambition of becoming something called a learning health system, which are very exciting. But we'll have to leave it a few more years to judge whether we're fully still in those. So with that, I think I'll cross over now to Gill. Gill, are you chairing questions?
I certainly am.
Fantastic.
I think Annie in the background is going to do some wonders of technology so that people can come off mute if they so wish and feel able to ask some questions. So please do let me know if you want to ask any questions, or put some hands up, put something in the chat. I'm going to ask if Tim Antis wants to come off. Hello, Tim. I thought you might. You've got a couple of questions, and I feel like it would be better if you posed them yourself.
Thank you. Fantastic presentation. And what could be more important than working together to collaboratively make changes to the system? I'm playing around with complex system models and even system dynamic modeling. And you mentioned system mapping, and what you've done is a lovely flowchart or process map through different parts of the system. Do you make a distinction between system mapping and pathway mapping?
So thank you, Tim. We can definitely start there. Rich, are you happy to take that, or do you want?
I can certainly make a bit of a stab of it. I think we have, the ask was to map the system, not necessarily map the pathway. And I think with the learning disabilities population, it's very complex. There isn't a particular, if you do follow this route, you go to this point or you go to this point, depending on commissions, depending on how you enter the service. And I think that's what the system map is trying to show, the fact that there isn't a one easy flow map for you to do. I think when we work through the personas with the systems, it will help us manage that pathway flow that you're on about.
Yeah.
So I think they are two separate things. I think at the moment we've done a system map, we haven't done a pathway or process map.
Thank you.
I think it's also fair to say we tried different ways of mapping the information we were receiving, Tim. And we tried different ways of doing it and brought in a bit of an expert from our team to help us do it in the end. We are trying we are going to be doing some user experience based journey mapping as well once we've done a little bit more work on it, because we feel that it's complex for everybody. So it'll be lovely to pull that out a little bit more. Tim, you have got a couple of questions in the chat. Do you want another one?
No, I'm good. If other people want to, you've responded in the chat to most of them. I may raise my hand again, but let other people ask questions too.
I can't see any other hands up at the minute. I do have one for Ruth that if nobody else is going to jump in first. We've been reflecting locally that maybe many people on the call will be doing the same about the NHS 10-year plan and the changes and implementations that's gonna make us think about. So, Reece, from using this tool or this whole system approach tool, do you think the 7-phase whole system approach may be a useful tool to consider alongside the 10-year plan?
Yeah, I think that when you're considering, well, what it's really useful for is when you've got, you're trying to make a change that involves multiple stakeholders, organisations, etc. It's how do you bring them together to sort of stop working in silos, understand and move forward on a complex agenda, if you like. So I think any of the shifts, you know, sort of from, if you're thinking of taking something from hospital to community, or something from thinking about perspectives of treatment, prevention rather than sickness. Yeah, I think that the whole systems approach could be a really useful way of getting the appropriate stakeholders together to really consider how you might approach those shifts.
Thank you. Yeah. I think it's a really useful tool from using it a few times now. I think one of the mentions in the chat was about, are we seeing any link to Cotter's 8 stages of change? And I noticed you responded, Ruth. I don't know whether you want to elaborate on what you said you found.
So I think that, and I think the Hinsel will relate to this, which is when you've been working in, I mean, I've worked in improving how things are done through the NHS at various different levels, and you're not often aware of what has influenced your thinking. So when I see the Cotters, I can absolutely see it through everything that we're doing, but it wasn't a conscious effort, is what I'll say. I didn't look at Cotters and go, right, I'll apply that. But when you look through it, I think anybody who works in a HIN will look at that and go, oh yeah, no, we do definitely create a burning platform. We create urgency. We build a coalition. These are all definitely how we work. But I couldn't hand on heart say I definitely use Cotters to do that. And I don't know if anyone else, if you have, Gill, Kate or Richard, consciously done that, but it's definitely ingrained into the way I think we attempt to do improvement, isn't it? Does that help?
So. Yeah, no, I'd agree. I don't know whether Kate wants to jump in or Rich at this point, but I feel like that's change management, isn't it? In terms of that's just our routine role for the improvement work we do. But I definitely see it with the whole system approach, and it's a, like you, do I use it in a day-to-day thinking?
Yeah, is it consciously or not?
Not so much, but it is change, large-scale change would follow it.
Yeah, I think it like how long ago it was. So I did when I first graduated, I did you do your postgraduate. I'm a pharmacist by background, so you do a postgraduate sort of qualification when you're finished, and mine was on change management. So there is every chance that I probably did study it 20 plus years ago and just don't remember. But the fact that you then apply it day to day, I think it becomes sort of almost like oxygen, doesn't it? Some of these change management principles that then get built into the programs that you've done. Yeah.
Jess, do you want to weigh in?
Hiya, yeah, it's just a quick question. And really impressed with what you guys have done. It's only a quick one and probably not as relevant, but are you guys looking to do more of these sorts of projects once the opioids are finished on like smaller and more community-based issues?
It's a really good question.
Yes.
So what we tend to, so from a national perspective, we go through a prioritisation process, and we've set some priorities between now and 2027. And one of the main ones that has come out from the nation wants to work on is that work around behaviour that challenges learning disability and psychotropics. So that's where we're at the moment. We're using it for that particular approach. Because of the origins of the Public Health England model, that was done at a place level, and that was done on obesity. So I think that the model can be used at place level. I think smaller than that, so if you used to think about a neighbourhood approach, you could potentially use it, but I think that you may run into issues around when you've got a neighbourhood, you're talking about hyper localised services coming together, and what you'd miss out of there potentially is how are you involving your trust that would work less hyper local, how are you involving say your mental health services. So I do think that you can't go too small with this whole systems approach. I think you're probably looking at place level and bigger. Does that help?
Yeah. Do you because obviously it's challenging behaviour, does dementia fall under that, would you think?
It absolutely could do, and it's something that we considered, but it's kind of a separate thing. But you are right, there is definitely parallels and an overlap. I think we've heard that, haven't we, Gill, throughout the engagement that we've done on the learning disability and behaviour challenges. We specifically wanted to work with learning disabilities on this one because that's what the nation sort of requested. But I do think absolutely dementia, there's probably going to be learning that comes out of the work that we do with learning disabilities that we hope we can potentially lend over to dementia as well.
Okay, thank you. I won't anymore. It's just so complicated, isn't it? It's like,
yeah. And I think you're right. And I mean, the problems themselves are complex, and then it's about trying to distill down what is going to be the focus, because you could get completely distracted, couldn't you? And in order to have the focus and the impact, we try to put a ring fence around it. It is learning disability. It's not learning disability plus autism, although they may have autism, so it's not autism standalone. So there's all these processes we go through to sort of define who we're working with, and then off we go, and then we build a whole systems approach around that. But absolutely, there's learning that can fall out from all of these programs that can impact other similar scenarios as well.
Lovely, thank you.
I would reflect just that in our local Health Innovation East Midlands, we've reflected at how successful the approach has been and are planning to adopt it to other programmes, which I think might be why Kate's got her hands up now, because she works on other programmes as well.
Okay.
Yeah, so I was just going to say that actually, obviously, I was lucky enough to work on the opioids one, which I talked about, and then handed the reins for MedSip over to Rich, and I've actually moved on to a different programme. But what I would say is, obviously, it's not the principles of the 7-phase approach are there and aren't necessarily translatable to every programme, because some are too big to go into it and etc., and some are too small. But what I would say is a lot of the learning, even personally for me, means that I think significantly wider. So it's about, even regardless of what we're doing, it's about not just focusing on that one trust, that one service, that one issue, because of the bottlenecking that it can have, and actually understanding the whole system, even if it's not the full approach that you're taking, helps you to really think much wider and who else needs to be involved. Or even a case of, okay, this particular piece of work that I've done, or trust has done, or service has done, has got to a certain point where you think, why can't we make it anymore? And actually, what are the external factors that are happening on other services that feed in that we could then potentially network and see whether bridging that gap could then support further improvement. So I think, like Gill said, we are looking into it in other programs, maybe not in quite as stricter way, but looking at those principles and how those principles can translate.
Okay, cool.
I think that point you made there, Kate, about how it makes you think differently is the key, because I think as every single healthcare professional will go in with a certain lens into any situation. We all do, it's what we're paid for. Pharmacists are paid to go in with a pharmacist lens, nurses go in with a nurse's lens, etc. But the whole systems approach challenges you to think wider than that. So we often have to say to the pharmacists, yes, but what are the alternatives to medicines? How can we get upstream of this? And they go, oh yeah, because they're obsessed with, well, I could do a med review, and I could, which absolutely is valuable. So it's the wide stakeholder engagement and making people think wider than their comfort zone, I guess, and what else is influencing this is really valuable and something you can take to most problems, I would say.
Yeah, brilliant. Yeah, because that's the problem I often have, is it's almost too wide and you don't know where to start almost.
Yeah, so that I agree. And so there's something about you can go wide and then you narrow in. So understanding the problem from a whole system perspective is super important. Even if you do decide a whole system approach not appropriate, we'll focus in on this bit, but you're at least cognizant of the whole system and how what you're doing might impact, even if you focus in on one. So I think I'm always going to advocate whole systems, because I'm a patient safety specialist and we love to look at systems. So
I think we're about to run out of time, unfortunately. We do have a couple of polls we would love you to complete. I think, Annie, are you able to launch them? If you could complete them before leaving today. I just want to finish by saying thank you so much for joining us today. We've really enjoyed spending some time with you. Thank you to all the speakers. This is being recorded and will be available on the Health Innovation Network website after this event, and I think Annie will be communicating with you when that's available. So please do, we do value your feedback, so please do complete the poll before you go. It should only take a few minutes. And just again, thank you very much for your time today, and enjoy the rest of your day.